Please proceed. Thank you.
Thank you. Thank you. It's a great honor to be here. I'd like to thank Dr. Del Val, Dr. Zavala, Dr. Gonzalez-Chan, and Dr. Uribe for the great honor of being here with you to really learn from all of you. If I had to share one word that I think is the future, that's integration. Collaboration and integration, those are the two words. So I'm going to share with you a vision that we've developed at Mayo Clinic for precision individualized surgery. And this is a vision that I hope Médica Sur and Mayo Clinic can work on together to really advance neurotherapies. So the human brain is the frontier. 100 billion neurons, 1 trillion supporting cells. Every neuron has 30,000 connections. If you had that many connections on Facebook, your life would be in trouble. And this human brain is the producer of these magnificent works of art. It is who we are as a species, unparalleled as far as we know in the universe. It is the same organ that drives us to go to Mars. But our greatest strength as a species is when we gather around a campfire like we are at this conference. When we were in Africa early in our days as human beings, we were not the strongest species. We could easily be hunted, but when we were working as a team, in a group, we were unbeatable. And that is the important message. But once you have a plan around the campfire, innovation in the future requires an uphill. You have to have a plan, and it's almost always an uphill up the mountain. It's not easy to innovate. It's not easy to move a field forward. You have to work together, and you have to accept the challenges along the way. There are many threats to the brain, aneurysms, you've heard about some of these things today, tumors, spinal diseases for the rest of the neural axis, degenerative diseases, etc. And we can do a pretty good job today. You heard from magnificent speakers. The endoscopic and skull-based talks you've heard are magnificent. This is a tumor that compresses the spinal cord from the front. We can work in a team, and we can take out tumors that are very difficult, but can we do it better? So precision individualized surgery, what is it? It's safe, it's less invasive, it's patient-specific, designed for the patient. It's the right choice every time, the right procedure, it's predictable, efficient, and with a great outcome. The problem with conventional surgery, it's an average treatment for the average patient. It gives option, patient usually chooses sometimes. Surgery without practice, operating based on anatomic knowledge, which is of course important, but there's not a lot of integration of technologies that could be helpful. So we've outlined this vision, a map towards precision surgery. We think it's going to involve a number of things, including simulation science, mapping of the brain beyond what we can do today, artificial intelligence, imaging during surgery, operating in the MR scanner, or better integration of imaging, robotics, and technology and device innovation, and bringing it all together. So I'll start with simulation science. So this is a patient from Greece with an aneurysm. She's diagnosed with an aneurysm, unruptured. She sees 3 doctors. Doctor number 1 says don't treat. Doctor number 2 says clip the aneurysm. Doctor number 3 says coil the aneurysm. This is a common scenario. So the patient's confused. They call Médica Sur or Mayo Clinic. And ideally, you start to think about this before the patient even arrives. So we can print the disease. This happens to be a tumor, but you can print the aneurysm. You can create a hologram of the disease, which is something we're using now routinely. Incorporate tractography if it's a tumor. And this is actually in our clinic. We can create a hologram and walk through the pathology. This is just an example of an AVM, a cavernoma, and a tumor. We can actually walk the patient through it, but we can also walk the team through it and really hopefully get to better decision making. This is a metastatic tumor that we resected a couple weeks ago, creating a hologram that we can use before surgery, during the clinic visit, and during surgery. And then you can create a physical model of the aneurysm to decide whether clipping or coiling is better, or maybe observation. You can create a physical model that you can get, then you can actually create a hemodynamic model. This is a physical model of 2 aneurysms. On the left, it's a real aneurysm being coiled. On the right, it's the physical model. And technically, I can't tell the difference physically. And the result looks pretty good on both sides. And the good thing here is the team has practiced. You've tried it the night before or the week before. You can inform the patient which device works best, and you're going to be more efficient, and you already know the working view, so your time in the angio suite is less, and your hospital CEO will be happier. And then you can take this to the clinic. So here's a patient who has a carotid ophthalmic aneurysm, and we actually printed her aneurysm and brought it to the clinic, and we brought the tools, and I gave her a crash course on clipping. So here we're showing her the aneurysm. This is a model. She has all the tools. I'm going to show her how to clip her aneurysm, then she's going to hold the clip applier and do it herself. And imagine how how empowered the patient feels to be able to do that. The only challenge is the patient said, well, shouldn't we come from this angle? I said, wait a minute, I'm the teacher here. So there is some downside to egalitarianism. So, and then you can scale this, perhaps as we get better and better at this, using physical printing where it makes sense, using holography where it makes sense, we can start to really incorporate this into our daily routine, into our conferences. Mapping the brain. I think the brain is an amazing frontier. We have brain and the space are the two big frontiers for humanity today. And we have this conundrum with gliomas. When you have a brain tumor, on the one hand, the more you resect, the less the chance for recurrence or the longer the time to recurrence. But if you resect a tumor and cause a neurological deficit, you've negated the benefit. And so where do you draw the line? And so one of the ways we have to start thinking about this is with better brain mapping. We can do this today at Médica and Mayo Clinic with a functional MRI, but how do we advance this field? So you can go from 2D imaging to three-dimensional tritography and look at this in a simulator before the surgery so that Dr. Del Val and your surgeons here at Médica can go in with the best possible plan, avoiding the tracks, which are so important to function, yet getting maximal tumor resection. This is real-time tractography. And not every brain is the same. My brain is different than your brain. You're probably a lot smarter than I am. Dr. Del Val's brain is a little bit different than mine, and so on and so forth. This is the brain of a musician. So musicians have a bigger corpus callosum than non-musicians. So we have to start to individualize the mapping. And so this is a jazz pianist. He's one of the most famous improvising pianists in the world. And so he was put into an MR scanner. What we found was fascinating. It's not so, the red is activation, blue is deactivation. So when you improvise, you actually have to shut down some of your brain. And so we've always thought about it in terms of activation. So his brain and his approach to his tumor should be different than the approach to my tumor. We also know that musicians and non-musicians activate their brain differently. So on the left, same piece of music, non-musician listening to the music, and then a musician. So the point here is that you have to individualize the map. You see, a musician activates much more of their brain than a non-musician, and that's just one example. So we have great preoperative imaging, individualize the mapping, but then you have to make it real in the OR. So you work with your neurology colleague, your electrophysiology colleagues, to map the brain further during surgery. And we do this with grids and superficial stimulation, deep white matter stimulation, suction stimulation, techniques that are perfected at Médica Sur with Dr. Zavala and his team. And then if they're a musician, we ask them to bring the instrument to the OR. So if we stimulate and they have a problem, we can tell that we're running into issues. So this is a patient with a Wernicke's area lesion, and she's a pianist, and she told me, if I wake up hemiplegic, I'm okay. We don't want that, of course, but she said, if I can't play the piano, my life is over. So we had to keep that in mind. We're still in the early phases of understanding how to map that, but certainly we're trying to factor it in. It's not just about saying 1, 2, 3 and moving your hand. There's much more to life and quality of life than that. Then we have 5-ALA fluorescence. So now we can, we've always relied on white light, but we can actually now inject an agent to light up a tumor so we can do more than what we can achieve with white light. So this is an example of a tumor where we thought we had a good result, but we inject the 5-ALA, we switch the filter on the microscope, and now we can individualize the surgery by seeing more of the cells. You're going to see here in a minute the 5-ALA get turned on. And now we see residual cells in red, so we can go after those tumor cells. So what about augmented reality? All our kids are playing with augmented reality now. The new microscopes are going to incorporate that great functional imaging into the surgical field. It's still somewhat primitive, but together between Médica Sur and Mayo Clinic, we can push this forward and see how we can improve outcomes and improve efficiency in the OR. It's about layering information on top of each other, physiological information, imaging information, and functional imaging. And now this is a cadaver study where you can see deeper layers than you are. So if you're still on the skin or the bone, you can start to see the tumor deeper than you, even as you're working, to increase efficiency. So this is going to require us to redesign the hospital. So at Mayo Clinic, We have a tumor OR, we have a vascular and spine OR, we have an MR room. We're now in early 19, we're moving these rooms next to each other, so there's going to be an MRI in the middle, a tumor OR for gliomas, and here a vascular and spine room where we have C-arm robotics for intra-op CT. So you can do interventional MRI, you can move a patient from here to here to get an intra-op MRI. If you're taking out a spinal tumor, you can get an intra-op CT and get an MRI as needed. So this allows us to integrate these imaging modalities. So the idea is, how about operating in real time? That's the concept of intra-MR procedures. And so this is a pilot study on infusing a drug into the brain in real time using interventional MRI. And this is going to open up a whole avenue for us for clinical trials and therapies. Imagine infusing this into a glioma or infusing a drug specifically into the basal ganglia for degenerative diseases. And this opens up a whole new world of research opportunities. This is an example of a brain metastasis in a patient who had prior radiosurgery, gamma knife to a deep brain met. She was doing well. She was actually a CEO of a company. She had a board meeting in 1 week in Europe, but her tumor was growing. So what do we do? So open surgery would have been kept her in the hospital for a couple of days. It was a deep tumor. So rather than do that, we use something called laser ablation. I'm sorry for the company name here, but just to show you a video. This is a cath that can be put in stereotactically, and then the tumor can be heated and kill the cells. And she was actually out of the hospital the same day and was able to travel to her board meeting in Europe. So this is an example of precision, individualized therapy using the right tool on the right patient. What about robotics? This is no longer science fiction. We are in the process of installing robots at Mayo Clinic to help us with cranial surgery, whether it's depth electrode placement, and also for spine surgery. We just acquired the Mazor robot to help us place pedicle screws more efficiently. And that's just the beginning. This is the 1.0. Imagine in the future, maybe the robot will make me coffee on the way to the OR, so that should be fun. What I think it's going to do is increase our efficiency. So today, if we have a complex spine tumor, and maybe that we get an angiogram on day 1 if it's a renal cell metastasis, we embolize, then we go to the OR, and then we get a post-op MR. Well, with our new setup, this could be 2 to 3, 4 procedures. In our new setup and our new hybrid suites, we can combine that all into one procedure. So it's greater efficiency, better for patients. You can angiogram, embolize a tumor, resect it, check your result with an MRI, bring the patient back, get a new robotic C-arm CT, incorporate that into the image guidance system, and then fuse the patient. So that's all can be, and that will lead to better outcomes, I think. And along this way, with simulation, there's an opportunity for technology and device innovation. We have to rethink how we do things and design tools that some of the tools we use in the OR are still from 1920. And so we have to rethink about how to make our devices smarter. So we hooked up with a company recently that does interventions in MRI, and we designed a catheter to evacuate brain hemorrhage in the MR scanner, just as a little example of what we can do when we start to bring these technologies together. So we know that brain hemorrhage doesn't have good solutions. We know that volume correlates with bad outcomes. So above 10 cc's, your outcome starts to decline. Above 20 cc's, it's usually very bad outcome. Above 30 or 40 cc's, forget about it. You're going to do very poorly. But we know that open surgery has some downside. It's invasive, and it hasn't been proven to help. There are a number of trials ongoing now, MISTI and Clear IVH, that was just concluded. Actually, MISTI is ongoing to see if evacuation of brain hemorrhage can be effective. And we know from those trials that the more accurate the evacuation, the more expeditious the evacuation, probably the better. And so what if you could do it in real time? Because when we take these patients to the OR, we are a bit blind, even if we're using an endoscope. So this is just in our lab. This is actually cranberry sauce, but this is a model in MRI where we're evacuating the hemorrhage, quote unquote, in the MR scanner. So this is a real time, and imagine if you could do that in a patient. So we just went to the FDA with an MR compatible catheter. We hope that Médica can be a test site along with Mayo Clinic. We hope to have it FDA approved soon. So this was just my introduction to precision surgery using simulation and 3D printing. I'm going to come back after Dr. Murgala's talk and show you some cases where we're using some of these concepts to treat patients. Thank you.